Okay, my name is Dr. Slewa-Younan and I'll be talking to you about cognitive behavioural therapy in today's lecture. So these are the learning objectives that we will cover at the conclusion of this lecture. Firstly, we're going to talk a little bit about the historical origins of CBT or cognitive behavioural therapy. We'll then spend some time outlining the model and the theoretical underpinnings of CBT. And then I'll provide some examples of the most common CBT strategies that we use today in clinical practice to target people who present with either primary or secondary low mood and or anxiety. But firstly, let's talk about what is cognitive behavioural therapy. Broadly defined, the broad consensus is that it's a psychotherapeutic approach that aims at solving problems that emerge from dysfunctional cognitions, dysfunctional behaviours or dysfunctional emotions, and it uses a goal-oriented systematic approach. It's usually a short-term intervention and it's been practiced in its current form for well over 30 years. It has a very strong evidence base for the treatment of mood disorders, anxiety disorders, eating disorders, and even some aspects of psychosis, such as positive symptoms of schizophrenia. It is one of the few psychotherapeutic interventions that is covered under Medicare's Better Access to Mental Health Care, and that's because it has a level 1 evidence base, which is the highest type of evidence, basically consisting of findings that have emerged from meta-analyses of randomized controlled trials. Now, it's been argued that what makes CBT so effective is that it has such a clear underlying model and structure. Within the CBT tradition, it is assumed that psychological problems are acquired and therefore can be altered using the same learning processes that were developed to cause these problems. So the learning processes that we are talking about here is classical conditioning and operant conditioning. This viewpoint is very useful for understanding how some simple anxiety disorders occur because it places the greatest emphasis on the immediate environment and the resulting behaviour, and we can use this method to address some simple learning processes to tackle these problems, and I'll talk about that in the next 2 slides. But of course, psychological problems are more complex than that, and sometimes more distant early life experiences will play a role in their development. And so for this we turn to cognitive theories, hence why we call this cognitive behavioural therapy. Now pictured here are 2 people who are considered to be the founding fathers of CBT. Aaron Beck is a psychiatrist whose seminal work on depression in the 60s and 70s at the University of Pennsylvania led to numerous outcomes, including the most widely used self-report scale of depression called the Beck Depression Inventory. And at the time of this lecture, continues to be quite active, despite being in his 90s. The other person is Albert Ellis, and he was a psychologist who worked at New York University and is best known for his work on rational emotive behavioural therapy, which is another kind of slight version of CBT. Now, at the heart of cognitive theories and CBT in general is the wisdom that stems from ancient Greek traditions and can be best summarized in the statement, people are disturbed not by the events alone, but by the view they take of them. And we'll discuss what this means in the next few minutes. But let me just kind of briefly talk about some kind of simple behavioural strategies that tackle the really simply acquired anxiety disorders. So here we're going to talk about the use of learning processes to treat specific phobias. Now, the first one that we talk about is called flooding. And as its name suggests, it is a forced and prolonged exposure to a feared stimulus or object. It was first reported by a psychologist named Thomas Stamp in the 1960s, and he demonstrated that if you expose a person to vast amounts of their feared stimulus, they would initially demonstrate extreme anxiety. He also referred to it as people imploding. But because the mind cannot stay anxious forever, once they realize that nothing terrible is going to happen, the patient starts to calm down. And so they start to, from there on, associate the feeling of calm with a previously feared object. And in terms of a learning process, what we're talking about here is extinguishing a conditioned response. So the conditioned response being fear. Now, one very real problem with flooding as a technique for eliminating phobias is that it places a great amount of stress on the patient. Now, often you'll find patients are not willing to volunteer for such a therapeutic technique. And so, thankfully, there is another technique, one that's probably much more common, known as systematic desensitization. Now, this was developed by South African psychiatrist Joseph Wallop in the 1970s. And so instead what we're doing here, instead of removing the feared response through extinction, we're replacing it with a more adaptive one, so replacing fear with relaxation. So let me take you through what a typical program would include. So firstly, after you've conducted a thorough clinical interview, you would identify a patient's fears as concretely as possible. So for example, someone may come in with a fear of being in an enclosed space. You would work along with the patient in developing a list of different imaginary situations that would provoke this fear. And this would range from, for example, reading about someone sitting in a cockpit of a jet fighter through to them imagining being trapped in a mine shaft. So you would take these fears from the lowest to the most highest fear provoking. You would then train the patient in deep muscle relaxation and other relaxation strategies. And then once the patient could reliably demonstrate relaxation, so once they knew how to bring themselves into a state of relaxation, you would start to refer to the previously created list of fears, and you would start from the lowest fear. You would continue discussing this fear until the patient started to feel discomfort, and the session would be terminated. At the next session, you would begin with relaxation and recommence with the list of fears. Now, therapy is successful when the patient can imagine the most feared situation and perhaps even be exposed to it without showing a feared reaction. So we're going to move on to learning outcome 2. Now, this is basically looking at the principles that guide CBT, and they can really be summarized by these 4 points. Firstly, CBT is an intervention that is based on a case formulation that we develop through the CBT model. Secondly, CBT requires a really good therapeutic rapport or relationship between the patient and the therapist, and that this needs to be seen as a kind of collaborative relationship. Secondly, CBT is strategic in nature, and so it allows it to be a relatively short-term therapeutic approach. And that's because it tends to focus on present or current time problems. And finally, CBT uses a variety of techniques that allows for long-term change. And because of that, because it's very educational and inductive in nature, and it requires regular repetition, and this is done by giving patients homework tasks in between sessions. Now, at the heart of CBT is this very simple model, which is often referred to as the ABC model. Now, this model basically states that the way people think about the situation will influence the way they feel and behave. So specifically, A stands for the activating event, B represents the automatic thought that you have about this event, and C represents the consequences of these thoughts. So this is what, how we feel or what we do, our actions. So let's put this model to action using the case study. Let's take 2 friends. Their names are Dan and Jason. And these people are lawyers who work in a large law firm in very similar roles. One day they hear that their names are on a list of people who are going to be made redundant. So let's take Dan. Now, Dan is a 33-year-old married male and he has 2 young children. Now, his automatic thought is, this is terrible, I might never get a job. What will my wife think? She may even leave me. Now, as a result of these thoughts, he starts to feel depressed. He wants to give up, and the resulting behaviour is withdrawal. Jason is a 37-year-old married male, and he has 3 young children also. His automatic thought was, well, this is really bad. It's a scary situation, but on the other hand, I really wasn't happy here, so this may be an opportunity for me to try something new and different. As a consequence of these thoughts, he's concerned and he's anxious, but he's also hopeful, which results in a behaviour that is engaged. This is an example of a same situation being praised differently by 2 people who are in similar life circumstances. What's important to note here is that although Jason shows a more adaptive response, he's still concerned, and that is appropriate. We wouldn't expect someone not to be concerned. Mourning a loss is not necessarily a maladaptive behaviour. It becomes a problem when it becomes prolonged or leads to significant withdrawal. And this is what we term a vicious cycle or a self-fulfilling prophecy. Now, while the ABC model helps to explain how the same situation can be viewed differently by people, it doesn't explain why. And so for this, we need to turn to Beck's cognitive model, and this is what we'll be showing you next. In this model, he proposes that maladaptive schemas are established from difficult life experiences, neglect of important needs, and modelling with early parental role models. The first part of the model is what we refer to as a schema. Now, a schema is a cluster of interconnected core beliefs about oneself, about significant others, the nature of the world, and probable course of future events. It's usually articulated in absolute statements. So often you'll see people say things like, people are not trustworthy, I am worthless. In depression, you find that often these schemas are centered around loss and absence, and in anxiety, schemas tend to be focused around danger and hostility. It's important to remember that people will often have both adaptive and maladaptive schemas, and at certain points at time, they can either be latent or active. So for example, for depression to occur, a major life event will trigger and activate a latent maladaptive schema. The next part of the model are assumptions, and these emerge from schemas and are usually articulated or take the form of conditional statements. So if A, then B. If I'm not liked by everyone, then I am worthless. I must be perfect, otherwise I am worthless. The final part of the model are automatic thoughts. So these are the thoughts that we were referring to in the ABC model. These are really rapid thoughts that can occur so quickly that often you'll find patients, or even indeed ourselves, are unaware of them. And yet they have such a strong influence on our emotions and our behaviour. So let's go back to that model of Dan. Now say after some time of being depressed, Dan is referred to for therapy. After a thorough assessment, the clinician finds out the following. Dan was an eldest son of 2 boys who was raised in an isolated rural town. At the age of 9, his father died in an MBA and his mother remarried 3 years later. Dan reports that his stepfather was a really strange and tormented man who would often binge drink on the weekends and become verbally and physically abusive, shouting things like Dan should make something of himself, Dan should become better, Dan should be an athlete, and so on. Now, if Dan didn't achieve top grades or excel at sports, then his stepfather would become enraged. After some time, many years of living in this abusive marriage, his mother then leaves him and his brother in the care of his stepfather and walks away. So from these early life experiences, you find that Dan has developed these following schemas. I am worthless, the world is a strange and unreliable place, and that people cannot be trusted. If you delve a little bit deeper, you find that Dan has formulated the following assumptions. I must be perfect at everything, otherwise I am worthless. I have to have a high-achieving career, otherwise my wife will leave me. So you can see from this case formulation how easy the life stressor of being made redundant activates Dan's underlying schemas, because his childhood is centered around loss. Now, later in a session, Dan reveals how on the way to therapy one day, he ran into a friend who didn't say hello, who looked at him and didn't say hello. So going back to the ABC model, which is coming into it here, as you can see, we asked Dan, well, what did he think of this event? Dan was really quiet for a moment, and then he says, well, I thought perhaps it's because I'm unemployed. No one really likes me. I'm nothing anymore. And as a result of that, Dan stated that how he was struggling that day to come into therapy. He just really wanted to go home, withdraw, feeling really tired. So you can see how once a negative schema becomes activated, even minor day-to-day stresses will trigger negative automatic thoughts. Now, these negative automatic thoughts typically lead to problematic moods, physiological changes, and behaviours, and so on. And so, again, we see this vicious cycle, which leads us nicely into our next learning outcome, which is what, as therapists, we can do using this cognitive model. So CBT aims to train people or patients into two aspects. Firstly, we arm them with skills to work on these negative cognitions, which are also known as cognitive distortions. And secondly, we ask them to participate in behavioural strategies which serve two purposes. Firstly, they are to act as behavioural experiments which will aim to disconfirm the patient's original negative thought and to hopefully confirm an alternative, more positive thought. And secondly, to help the patient be introduced to more adaptive coping behaviours and therefore strengthen them if they are, or strengthen them if they're already present. Identifying and challenging negative thoughts is the foundation of most CBT intervention. Now, firstly, this intervention has, or this type of technique has 3 steps. The first step is to teach the patient or instruct the patient on what are some of the most common negative types of thoughts. Secondly, we show the patient methods for evaluating their negative thinking. And thirdly, we inform them on methods on how to respond to and challenge these negative thoughts. And this final goal of instruction is to allow the patient to effectively use a thought record. And I'll show you an example soon. Identifying negative thoughts. Well, this uses a type of questioning method that can draw out a person's automatic thoughts and eventually help them identify their schemas in action. So we often kind of use a kind of questioning method of, if you ran into your friend and they didn't say hello, then how did that make you feel? And so on and so on. So we use a downward arrow to go, well, if this thought is true, what's so bad about it? What's the worst part of this thought? What does this mean to you? What does it mean about you? And so this is to draw through a process of kind of constant reduction of funnels to the most basic schema and to try and elicit that schema that's underlying in that person's thought processes. So here are some of the most common negative thoughts that people will often engage in. The negative thoughts are defined as biases in the way we interpret information that is consistent with and supports our schemas. Typically, most CBT textbooks will refer to a number of them, but 10 is probably, at least the next 10 are the most common. I'll take you through each one and explain them. So all or nothing thinking, or black and white thinking, is sometimes when you experience people or experience situations as one extreme or the other with no middle ground. So things are either quite successful or failures. Often it's the latter. There are no shades of grey. You see things as absolutes, with black and white thinkers being very definitive in the way that they think. So it's this will happen or this won't work. There is no room left for possibilities. Overgeneralizing. This is when you expect things to, for example, that have gone wrong in the past to continue to do so. So one defeat or mistake or unpleasant occurrence creates within you the expectation that this is bound to happen whenever you put yourself in the same situation. Now these types of thoughts can apply to people as well as situations. So if you've been let down by a person before, you continue to think that this will always happen. A mental filter or selective thinking is when you pick out a single negative event or detail and you will dwell on it exclusively so that your vision of reality becomes quite darkened or narrow. It's really the opposite of looking at the world through rosy-coloured lenses. What you're doing here is you're looking at the world through dark-coloured lenses. Disqualifying the positives is when you take a positive experience but you reject it, insisting that it doesn't count for some reason or another. So someone may say to you, I like your shirt, but instead of you taking that as a positive experience, you become quite cynical in the extreme, and you are constantly looking at the people's motives. The problem with this way of kind of constantly discounting the positives is that it really prevents the full development of a person's self-esteem. Mind reading is where you arbitrarily conclude that someone is reacting negatively to you without even bothering to check it out. Now, fortune telling, also known as jumping to negative conclusions, well, this is when you anticipate that things will turn out badly and behave as though this is an established fact. You might even be ignoring evidence that's contrary to that. Magnifying unpleasantness, this is where you exaggerate the importance of things. This is where you, for example, may exclusively focus on an error that you found in your report, and this mistake starts to make you feel well beyond uncomfortable. So someone may also find a mistake in their report, but they just kind of think about it and then let it go. But this person will spend an excessive amount of time dwelling on this mistake. Catastrophizing, this is a distortion that is even more extreme than magnifying unpleasantness. This is when you turn things into life or death situations. You start to attribute extreme and horrible consequences to the outcome of events. So for example, a spot on your arm, well, this is a skin cancer, a headache, I think I have a brain tumour. And you start to catastrophize very minor situations. Emotional reasoning, this is where you assume your negative feelings that you're having are necessarily reflecting the way things are. So I feel not terribly bright, therefore I am not bright. And finally, living by fixed rules. This is where you motivate yourself by should and shouldn't statements. Often these statements will occur when you are trying to live up to perfection. Now, there are some distortions that are more common in certain disorders. For example, living by fixed rules or disqualifying positives tend to be seen quite often in depression, catastrophizing in anxiety. The presence of such distortions can vary from patient to patient. Often patients find difficulty recognizing their own negative automatic thoughts, and so what clinicians will do is teach patients a process called thought catching. Now this can be done by in therapy itself by setting up difficult situations, and we use role play to then ask the patient a question such as, well, what just went through your mind just then, and what did you just tell yourself? Once your patient reliably understands the types of cognitive distortions or negative automatic thoughts and the process involved in thought catching, you can use what are known as thought records, and this slide demonstrates thought records. You can see that the first 3 columns are devoted to articulating the ABC model and how it relates to the patient. But the main purpose of thought records is to really address the inductive nature of CBT, and this is also known as Socratic questioning. So here what you're doing is you're teaching your patient to look for evidence for and against the negative automatic thought. It's hoped by regular repetition of this exercise, it will not only modify the patient's negative automatic thought, but eventually perhaps challenge their assumptions and find their schemas. In doing these thought records, I found that sometimes patients have trouble separating negative thoughts from negative feelings. And I'll show you an exercise that can help at the end of today's lecture with that. Now, another way that you can challenge negative thoughts is by inviting a patient to set up experiments that aim to test the validity of a negative thought or schema. You can start this process by initially doing it in session. So, for example, a patient may come in quite depressed and feel like they are completely hopeless and useless, and they have a belief that they can't do anything right. Now, you can start the patient with a very simple task. So, for example, ask them to read a passage from a book or write a shopping list. And then, when they can reliably do that, you say, well, look, that's a challenge to that automatic thought. You can actually do something right. Other examples include things like using belief surveys. Now, this is when you invite the patient to ask a number of friends about the degree to which their friends or family believe in one of their negative automatic thoughts. The patient should write these responses from their patients verbatim and bring them into therapy, and you can then discuss them and hopefully make an impact on the patient's negative automatic thought by showing that it's quite different from what the people view. Now, while cognitive therapy deals with automatic thoughts and schemas, both Beck and Ellis were very much aware of the need to bring behavioural methods into treatment. And so while pursuing changes to schemas in cognitive therapy is really important, it's also important to remember that cognitive changes can also come about from very simple behavioural changes. So in essence, most of this type of work is centred around activating missing behaviours, building upon rewarding adaptive behaviours, and facing fears. And this facing fears is when we're kind of talking about exposure therapy. And one of the most striking things about depressed people is their body language. Often you'll be able to quite spot them because they're hunched over, their shoulders are turned in. It's as if they're shrinking before our eyes. These are people who are quite slow in their motion and their activity. So what we do in therapy is to address this withdrawal not only by looking at the lack of quantity but also the lack of quality in their continued activities. So something known as activity scheduling is where we initially begin by getting them to do more things. So get them to go for a daily walk. And then we gradually increase this quantity of activity by doing something that's better, so more quality of activity, things that mean something to the patient. Self-rewards is when we invite the patient to use tangible rewards. So we say, book yourself a massage, get a manicure when they've dealt effectively with things in therapy such as their activating events or negative automatic thoughts. It's no secret that patients who are often seeking treatment are those who have poor coping skills. So they have a difficulty in often self-soothing themselves, and they have difficulty interacting with people, so they tend to have poor social skills, and sometimes they are unable to make appropriate choices when they're faced with challenges. They have poor problem-solving skills. So this in itself is a very important task in CBT, addressing coping strategies, providing patients with the skills to face future challenges. And so in CBT, we focus on things like relaxation skills, which will help the patient improve their ability to self-soothe. We train them in communication skills, which will hopefully improve their relationship with others. And we develop the really good problem-solving skills so that they can make appropriate choices when faced with challenges. Previously in this lecture, I was talking about how often patients have difficulty sometimes separating their negative automatic thoughts from their negative kind of emotions. And this is a really simple process that you can use. It appears to be quite concrete, but sometimes this is what needs to be done, especially with those who have difficulty kind of capturing the difference between negative thoughts and negative feelings. So you develop this kind of an image, or you could perhaps do it on a whiteboard, where you present the situation and then you say, well, I could think. And so I think when the two girls are ignoring me, I bet you they're talking about me. So how does that make me think? Oh, well, what do I think about that? Well, I suppose I'm thinking, they don't like me. Then how does that make me feel? It makes me feel sad. Now, obviously, the more helpful side is where you try and generate some alternative thoughts. Well, I could also think perhaps that they're busy talking about something that happened on the weekend. And how would this make me feel? Well, it probably would make me feel, like I'd like to have a conversation with them and see what's going on, or, find out how their weekend went. So, to summarize, CBT assumes that problematic thoughts, feelings, and behaviours are patterns that are learned through the same process as normal thoughts, feelings, and behaviours. Now, these processes can include operant and classical conditioning, as well as other various cognitive processes such as modelling and identification. Therapy involves coaching patients into replacing problematic habits with more adaptive ways of thinking, feeling, behaving, and interacting with others. CBT is a collaborative effort between the patient and the therapist, and it uses analytic questioning through the use of analytic questioning, the patient is able to discover how their problems are maintained and how they can be modified. Thank you.